Robotic surgery is a type of minimally invasive surgery. Doctors Bahareh Nejad and Mohamed Ali from UC Davis Health joined me to talk about the pioneering method and how it's used. Next on Studio Sacramento.
At Five Star Bank, we create thoughtful solutions to help the capital region thrive, from economic development and education to public health and safety, issues that are vitally important to Sacramento's prosperity. We're proud to be part of the conversation and hope you'll join in.
This Studio Sacramento episode is supported by UC Davis Health, where doctors, nurses, and researchers share a passion for advancing health. Learn more about their latest medical innovations at health.ucdavis.edu.
Dr. Nejad, what exactly is robotic surgery?
That's a great question. So robotic surgery is similar to laparoscopic surgery. We kind of take it to the next level. So laparoscopic surgery is we make very small incisions in the patient to try to do the most minimally invasive surgery. And then we put ports in those incisions and attach the robot to those ports so that then we can unscrub, sit in a 3D console and do the surgery right next to the patient.
A 3D console. So you're not actually even touching the patient, Dr. Ali?
That's right. So the surgeon, one surgeon is at the console, really controlling the instruments so that all of the hand movements at the instruments at the console level translate 100% to what's happening at the patient level. But you also have a surgeon who is at the bedside with the patient.
And what do they do, since they're not actually running the robot? They're just kind of standing on the side to make sure everything goes okay, or?
Well, actually, that's a very good point. In our early days, that was part of it, right? Because we wanted to make sure that all of the patients, had the utmost safety. But right now, primarily they're assisting. So sometimes they are helping, they're exchanging instruments, because you may have one instrument that you're doing work with, and you want to exchange it for a different instrument. They also help the configuration of the robot arms to make sure that there's no collisions of the robot arms. And actually, I feel better about it because it does ensure some safety.
Okay. Dr. Nejad, I'm curious though, is that when we think of surgery, we think about somebody coming along with a scalpel and, cutting us open and all that sort of thing. So, the surgeon does that in order to be able to see what's going on inside. Mm-hmm. How is it that sending a robot in there allows you all to have as good of a view to make sure that whatever it is you're trying to either put in or take out, you've got the full view of the field?
What's amazing is we actually have a much better view. And so
Really?
Oftentimes, when I have people who are new to robotics or laparoscopic surgery and they come into my OR and they say, well, why don't you just open so you could see better on a very complex case with maybe a lot of scar tissue or large pathology? And I say, I'm going to see much better like this. So we inflate with CO2 gas. And then, like I said, the console is 3D. And so I can see tiny little blood vessels, so we can minimize blood loss because we can block any bleeding from happening before it occurs. I can see much better in 3D than I can in 2D. And so also with the robotic device, our instruments have a 360-degree range of motion, which is better than my hands and better than laparoscopic instruments. So all those reasons, I have better mobility and better visualization with the robot.
And in your practice, what are the typical range of surgeries you're using this for?
I primarily do them for robotic hysterectomies. So people who have very large fibroids, really heavy bleeding, and they would otherwise get a large open incision, up and down incision, possibly be in the hospital for 3 to 4 nights. And my patients, over 95%, go home the same day taking minimal pain medicine.
Really?
Mm-hmm.
Wow. Dr. Ali, you have a history with this because the particular machine that UC Davis has is a Da Vinci, correct?
Yes.
But you've got history that sort of predates that. Tell us a little bit about how you first came into this field.
Well, I got actually quite interested in this in my training. It was a very new thing, that this idea that you can get a machine that a surgeon can control to do an operation, and the perspective behind it was, can we do things that exceed the limitations of our hands? and it's
It's an
you might-
interesting concept.
Right, and that's how this came about, because if you think about it, if I turn my hand this way, I'm done. But the robot isn't. If I can't get my hands down in a very small space and turn it around and work back and come back, and the robot does all of those things for us. So that's how I became interested in it, because as a trainee I said, gosh, I think this can help people. So when I came to UC Davis, just, like everything else in life, matter of good timing, it was at the infancy of the program. And we had just bought a robot. I started working on a system called Zeus from a company called Computer Motion that merged with Intuitive later. And it was interesting. It was a very different technology, but ended up being a really good way to learn in the beginning and be able to offer this to patients. I still remember the first patient. She says, "You're doing what?" And so I showed her. We went through videos together, and I still, believe it or not, that was in 2002, and I still see the patient occasionally. She still follows up with me, and I tell her, I said, "What were you thinking that day when we kind of talked about this?" And she looks at me and she said, "Well, you seem like you're a trustworthy guy."
That always helps in a physician, right?
That's right. Well, he's alluding to obviously shared decision making. And that's really important, as we explain what we plan to do, and it's a shared decision making process between us and the patient.
How do you make the call as to whether or not you use a robot like this, or whether you do it the old traditional way?
Very rarely do I do a large open incision for a hysterectomy.
Really?
Yeah, I would say once or twice a year. Yeah, so predominantly I can use the robotic system to do most hysterectomies that come my way, and myself and our department has become a referral center for complex cases that would be done differently in other places or possibly in the community, and they're sent in not only for gynecology and myself, but for many other specialists at UC Davis.
Give us a sense of the range of the specialists that are using this technology.
Yeah, it's super exciting at UC Davis. We have over 20 robotic surgeons. So we have from cancer oncology surgeries to ear, nose, and throat, head and neck surgeries, to thoracic and cardiac surgeries, urology, general and bariatric surgeries like Dr. Ali, gynecology. Those are really
That's a pretty broad range.
Hernia surgery, yeah. So we have a very robust robotic program.
So you had alluded to before that using this type of surgery, that your patients, and I assume this is true for you as well, Dr. Ali, that less blood loss, quicker recovery, I assume better outcomes, that sort of thing. There are cynics who say that healthcare is the only world where advances in technology drive up costs, not drive them down, right? How does this translate into not just the patient outcomes, but essentially being more productive from a bottom line standpoint?
Well, it's multifactorial. So first of all, I would say patient outcomes do drive down costs, because if we have fewer complications rates, less bleeding, less blood transfusions, fewer future infections, then we have fewer hospitalizations where patients are coming back, and obviously just better outcomes in general. If a patient has a large incision, the risk of bleeding and the risk of infection is much higher. So we want patients to get back to their normal lives as fast as possible. In addition to the fact that we're looking at a major capital investment, there is a maintenance cost to the robotic systems, but it's an upfront capital investment. Once we've made that capital investment, the goal is to do two things. One is to make our systems very efficient. So we want to be using those systems as much as possible and maximize their efficiency, in addition to increasing our hospital throughfare. So if we have patients who are having a minimally invasive surgery like a robotic surgery, and then they don't need 3 to 4 nights in the hospital, that allows more room for other patients to take those beds.
Interesting. Now, your practice, you do general surgery, but one part of your practice is bariatric surgery.
Yes.
And patients who are contemplating bariatric surgery a lot of times are very concerned about, just overall mortality.
Absolutely.
And what the effect of going, under anesthesia and going quote unquote under the knife is going to be. How has this made a difference in terms of the doctor-patient interaction and sort of the comfort that patients feel in accepting this type of treatment?
You're exactly right. I think the biggest thing is to maybe go back about 20 years, maybe 25 years. At that time, most bariatric surgery was done open with these large incisions. And for patients who suffer from obesity, probably the biggest risk of complications for them, actually, believe it or not, is due to their incisions. So they develop incisional hernias, and they develop all kinds of complications, incisional infections, and so forth. Probably the biggest advance in bariatric surgery in the past 60 years since the field's existed, I think, has been the advent of minimally invasive surgery, where we can do the same operations through small incisions. To give you an idea about the statistics, an obese person undergoing an open operation has about a 1 in 3 chance of getting a complication with their incision.
That high?
Yes, absolutely. Either an incision or a subsequent hernia. And that risk is about 2% if you do it laparoscopically. Now you can say, well, laparoscopy, we're talking about robotics. I think robotics specifically makes some of the tasks that we are able to do laparoscopically easier, and when it's easier, it's also safer. Also would like to underscore a point Dr. Nejad mentioned about the visualization. The visualization is spectacular, and it's 3-dimensional. Traditional laparoscopic visualization is only 2-dimensional, and I think that adds a layer of efficiency and safety.
When you're in the room with the patient and you're describing performing a surgery on them using this type of technology, what generally are the questions that you all are both asked?
First of all, people primarily want to know where the incisions are going to be and how big. And so that's one of the most common questions. And then for us, the second most common question is, how are you going to get it out? Because the incisions are so small, say, how are you going to get it out?
That is, let's pause right there for a second. Help us understand that, because when you're talking about doing a hysterectomy
Yes.
or large fibroids, and how big is the incision?
So most of the incisions are 8 millimeters.
So walk us through how you're going to get all of that out.
Yeah, so it depends. If I'm doing a hysterectomy for a medium to small uterus, once you do a hysterectomy, you have a natural orifice created, and that's the vagina. So we can remove the specimen through the vagina. But the majority of my cases are very large specimens. That's why they were referred to me, to try to do a very large specimen, theoretically this large, through very small incisions that are 8 millimeters in size. And so what I do in those cases is the incision that's in the belly button, I extend it to about 2.5 centimeters, which I can primarily hide in the belly button. And I put the specimen in a large bag and then take it out in very small pieces. It takes about 30 minutes.
Really?
Yes.
You put the specimen in a bag.
That's correct.
In the patient's body.
Correct. Bring the bag up.
Bring
the bag up so I can see it, so we don't lose any pieces.
Right, and then slowly cut it down to bite-sized pieces and bring.
That's right. That's right. We don't usually call them bite size.
Yeah, sorry about that. I'm hungry.
I'm just kidding.
Okay.
But yeah, so we cut them up into small pieces, and since we've got it down, we move pretty swiftly. It can take, a very large specimen can take up to 40 minutes, but.
40 minutes sounds blazing fast, though. I mean, traditionally, surgeries like that, I would assume, took far longer, right?
Yeah, they can take far longer. The 40 minutes is the part I was talking about, just removing the specimen. The surgery itself can take a couple of hours before that. So total, we're looking at about 4 hours with prep and setup and all of that for a large hysterectomy.
So I think about the medical students that are going through your programs at UC Davis and the residents. What's been their embrace of this new technology?
So it's been interesting for me to watch it over the years. I think when I first started, I remember I'd be in the operating room, and then, of course, because it was early on, we were still making sure that everything's okay, we're taking our time. So people would kind of peek their head into the window, what's going on in there? What are these guys doing? Because no one had ever seen it, and at that point, there were only 3 people doing robotic gastric bypass in the entire United States.
Oh, really?
Yes. So there was, I was doing them, there was someone in Los Angeles and then someone in New Jersey. And that was it. So it was this thing that no one had really ever heard of. So it went kind of from this feeling of wonderment to perhaps some trepidation, because it's like, I think one of the biggest disconnects, and maybe to piggyback a little bit on the question you asked Dr. Nejad, the main thing that I would hear from the patients early on is, you're going to be where? Wait a minute, aren't you like, so no, it's not like I'm going to be down the hall or down the street or whatever. We're right there, and we're fully engaged. So the biggest question I always got is, how does it work that the surgeon is sitting separate from the patient? I think as this has become commonplace, because if you go on YouTube now, you can see robotic surgeries posted on there, millions of them. And so I think it's become informational and commonplace. And I think now our students, their biggest interest is they sort of come in groups. The ones that are interested in surgery really are looking for the latest, the cutting edge technology, and so they're embracing it. So we've gone from kind of incredulousness to wonderment to really embracing in about 16 years.
Wow. How are these medical students and residents trained on this technology? I mean, is there a expanded level of coursework beyond what you all traditionally would provide?
Yes,
or?
absolutely. The medical students are observers. So at this level of surgery, you're not learning how to actually perform surgery in medical school. Once you've decided to specialize in some surgical field, then in residency, we train you in these very specific procedures. And yes, it is extra coursework. So we have self-directed learning and simulation sessions, both. So at UC Davis, we have a consortium with all of the UCs that we actually started here at UC Davis. And then we have a learning pathway curriculum. So we have them do online training first, watching videos, submitting, doing their modules. And then they do training with a simulator, which we have purchased with our robotic systems. So they can sit on simulators, which have ancillary monitors. And they do, it's kind of like video games, but it's surgery. And so you're doing a hysterectomy with your head in the console, with your hands in a robotic machine that is kind of a cartoon figure of a uterus, or many other procedures that are also in the simulator. And then you get scored. You get scored on your hand movements, on your efficiency. And so you get this scoring card. And then once you score over 90% on everything, we feel that you're able to help us operate on the patients. Ultimately, at UC Davis, we're always the surgeons ourselves, but we allow them to be our assistants.
And would you say, any observation on whether or not the incoming generations who have grown up on video games and, simulated immersive environments, were they quicker on the uptake?
Yeah,
than
we've actually studied this. Yeah, and so we have held simulator Olympics because we try to pin the specialties against each other and say general surgery versus urology versus gynecology, because a little bit of competition is always healthy. And so we've asked people, who get really high scores, 98, 99%, like, were you a video gamer? And the answer is often yes. Not always. Some people just have the natural talent, but it is often yes. And like Dr. Ali was saying, it has changed over time. When I started robotics 8 or 9 years ago, my resident learners were extremely opposed. This is going to take away open surgery from us. How are we going to learn open surgery? How are we going to participate if you, the primary surgeon, are just sitting at the console and we're just going to be the assistant? To now, how can I get on the console? How can I learn? How can I do this extracurricula? Because this is what I want to do when I graduate. So it's taken time on the resident side. The students have always been, I think, excited. But so it's been a procession towards, really being engaged.
It's interesting. I had the opportunity to, as a layperson, use one of these robots probably 10, 12 years ago. Mm-hmm. And I have to tell you, I wouldn't be invited back. It's a very complicated, it's like a bunch of Band-Aids almost on your fingers and, turning things around. How long does it generally take someone to become proficient at doing this type of work?
So in our field, we have that proficiency is expected to occur during residency training, which is after medical school. For our group, though, because the minimally invasive surgeons have sort of been the ones who've pushed the envelope on all of these, we have fellowship training. So it's specialized training after you finish your residency, we have one of those programs, and we graduate 2 fellows every year. So they finish their training and they come and spend a year doing the types of curricular work that Dr. Nejad mentioned in the lab, working on the simulators and so forth, but also assisting us in the operating room and doing the work. They finish with a few hundred cases. So these are folks that we send out to the community who are really quite well equipped to be able to do that on day one when they get to their jobs. And we've been doing that training for our program at least since 2003. We've graduated almost 40 fellows.
So you both have described this huge range of surgeries that are being done with this way. What's the next frontier? What can we expect over the next 10 to 15 years from this field and what its possibilities are?
Well, some are excited about and some I'm worried will take my job away from me. And so I think that a couple of things coming up are going to be more natural orifice surgery. So holes that already exist in your body, using those so that you don't have to make incisions. So I think in general, that's going to be moving up on the next frontier. I think artificial intelligence is the one I'm afraid of, but I think I'll be retired by the time.
Well, tell us more about the concern.
Well, I'm afraid that, we won't need me anymore once they figure that out. So I think that's going to be past my retirement, though I don't think we're anywhere close. And then I think one exciting thing, which I honestly don't know if we're near or not, would be remote surgery. And so if...
Wait a minute. You mean like telemedicine for surgery?
Correct.
Really?
Yeah, I think that would be really interesting, so that you could, in theory, help people remotely who don't have access to the surgeons that we do have access to here. So these are, again, theoretical things. They're not currently occurring.
Well, UC Davis in some ways was one of the birthplaces of telemedicine. And so it would seem, are you all actively working on this issue at UC Davis for a remote robotic surgery? Because it would seem like a natural for you all.
Well, we started actually in that process very early with that exactly the same mesh that you talked about. And what ended up happening, we actually got quite a ways down the road. There was actually a system developed to really be the interface for robotic surgery on a remote at a remote site. What ended up happening much more quickly than we could develop the technology. So the real crux and the real kind of issue ended up being latency. Is how much time, latency, time delay can there be in what I'm seeing and how I'm responding to it.
Oh, so in other words, if your bandwidth isn't high enough,
Yes.
it's like what we deal with when we're dealing with like Apple TV or something like that.
Exactly right.
And things kind of slow down and they're not
Yes.
real time.
Yes,
right.
That's exactly it. And so while we were really trying to solve that issue, it took us longer to solve that issue than it took for robotic surgery to be very prevalent across America. And so there really wasn't much that we could offer. In Canada, this is very commonplace. They're doing remote surgery I have some friends there. They do remote surgery with the robot quite prevalently in Canada, but the Canadian Telecom has developed the nationwide infrastructure to do that, so that they ensure that the bandwidth is there and exists for those operations.
That would be a real game changer in terms of dealing with rural health or areas that are impacted with.
And in theory, military applications,
Yeah.
things where we could really help people who are in need.
That is really exciting. So is there any expectation that we might be in a place where the work that you described can be furthered anytime soon?
I think in America, the challenge has been, and I would call it a challenge as a guy who is interested in the research, but really it's a blessing. And the blessing is that robotic surgery has become so widespread that most patients across the country are relatively close to a center that they can be referred to have this intervention. So there isn't really the pressure to do it, versus, say, in Canada, where there are some outlying areas where folks just can't get to a large care center. In terms of the trends for the future, though, I have held the belief for probably about 10 or 15 years that what we will be seeing is a merging of robotic surgery and endoscopy. So endoscopy, are used people that get screened for colon cancer with colonoscopy and upper endoscopy for ulcers. It is my personal belief that we'll have robots that are on these endoscopes, these flexible shaft endoscopes, and I think that's probably not too far in the future, and I think that's going to be quite transformative.
What will that make possible that's not possible today, or not possible to the extent you'd like?
Well, anything that we identify on endoscopy, we then have to go do a surgery. I think you'll be able to identify it on endoscopy and actually do the operation with no surgery whatsoever. It's going to be an endoscopic operation.
And finally, if you were to think about what is most exciting about the future of this field, Dr. Nejad, what would it be?
I think the things that we talked about that are on the frontier, but ultimately for me as a women's healthcare provider, it would be to get women back to their lives as fast as possible. So let's get you your operation in the most minimally invasive fashion and outreach to more women to know that this is out there, to seek out providers and physicians and surgeons who can provide this service for them, to seek out these centers that Dr. Ali was talking about. So if you're 3 or 4 hours away, I've operated on many people who live 6 or 7 hours away, who drive up because they've done their research. They have their operation and they're able to go home and just come back for a 1-month follow-up.
And that's about as great an outcome as we could hope for. Thank you both very much, and wish you well on your research and your practices. And that's our show. Thanks to our guests and thanks to you for watching Studio Sacramento. I'm Scott Syphax. See you next time right here on KVIE.
At Five Star Bank, we create thoughtful solutions to help the Capital Region thrive, from economic development and education to public health and safety, issues that are vitally important to Sacramento's prosperity. We're proud to be part of the conversation and hope you'll join in.
This Studio Sacramento episode is supported by UC Davis Health, where doctors, nurses, and researchers share a passion for advancing health. Learn more about their latest medical innovations at health.ucdavis.edu.
All episodes of Studio Sacramento, along with other KVIE programs, are available to watch online at kvie.org/video.